Okay, everyone. I'd like to welcome everybody to the Quests webinar series. Our host is online, and I will give you a brief introduction. So, our host today is Lucy Yardley, and she is a professor of health psychology at the University of Bristol and University of Southampton, and a National Institute for Health Research senior investigator with long-standing expertise in qualitative and mixed methods research. She initiated and leads the 10-year Digital Life Guide research programme, which has attracted over £30 million funding. Her programme of research addresses key questions such as how to maximise engagement with digital interventions and how best to integrate digital support for self-management of health with existing health promotion and healthcare services. She is addressing these questions through the development, mixed methods evaluation and dissemination of numerous digital healthcare interventions. So that's quite the CV there. And today, Lucy is going to speak about the person-based approach for developing and optimizing interventions. But before I hand over to Lucy, I'd just like to let attendees know that if they want to ask a question about the presentation, either select the Q&A section on the bottom menu or the chat option and type your question in here. And you can type a question in here during the presentation, and I will ask the first questions on your behalf once the webinar has concluded, depending on time, of course. So with that, I'm going to hand over to Lucy to begin her presentation.
Thanks very much. Thank you for inviting me. I know there's lots of interest in the person-based approach at the moment, and we've been doing various workshops up and down the country, and it's nice to be able to do a webinar for people that weren't able to reach those. So today, I'm going to start by just giving an overview, an introduction, and sort of putting the person-based approach in context with other approaches. And then I'm going to very quickly illustrate how we use it with the development of one particular intervention, because I think it comes alive once you see how it actually is put into application. And then I'm going to go in a little bit more detail into, first of all, how you use it for planning and then developing the intervention, and particularly our tools such as developing guiding principles, using Think Aloud studies, and our table of changes for deciding which changes we need to make to the intervention. And then finally, I'm going to talk a bit about using it at the implementation stage. And all the way through, I'm going to be giving you illustrations from some of the interventions we've developed. So this approach, we came up with it just gradually developed and evolved as we were developing interventions. So we kind of made it up as we went along at first, and we didn't tell anybody about it until we were sure that our interventions worked. But once we started finding that they were indeed coming out as effective and cost effective, and I think more so than some of the other interventions that we've seen around, we thought it was time to share our approach, because we're pretty convinced that it works. And by now, using it, we've done more than 1,500 qualitative interviews with users. So we've got a really good insight into what people like and what they don't like. Now, what we think is pretty unique about the person-based approach is that it combines user-centered design, which people might have come across, with evidence-based behaviour change. So the user-centered design is more from the HCI kind of discipline, and evidence-based behaviour change obviously more from behavioural science and health disciplines. Now, by using this combination, we hope that we can maximise uptake and engagement through the user-centred design, but also maximise the target behaviour change through our behaviour change methods. And therefore, the combination should lead to better healthcare outcomes, and has done in our trials. And by now, we have used this approach not just in the UK, but as you'll see from the bottom of this slide, we actually have done international studies where we've developed interventions. In this case, it was across Europe and also in Taiwan, so that's why you've got Mandarin at the bottom there. And we've shown that our interventions work internationally for diverse cultures and also for all ages and abilities. And again, I'll hope to illustrate that as I go along. And we've been developing interventions both for patients and members of the public, and also healthcare professionals in primary and secondary care. So we've done lots of ones that are sort of more public health, like promoting physical activity, weight management, smoking cessation, alcohol reduction, but also managing lots of different long-term conditions, so hypertension, diabetes, cancer, cognitive impairment that might lead to dementia, stroke, asthma, eczema, IBS, and symptoms such as back pain, emotional distress, flu, fatigue, and dizziness. That isn't a complete list, but it gives you an idea of the sort of breadth of applications that we've been doing. So what is the person-based approach? Well, the aim is to try to understand and then to accommodate the perspectives of the target users, so that you can improve acceptability, feasibility, engagement. But actually, we want to go beyond that and improve uptake, engagement, adherence, and outcomes. So the key to it, as you'll gather from the 1,500 qualitative interviews, is to do lots of in-depth qualitative research, but also mixed methods research, and to involve a very wide range of people from the target user populations, and I'll come back to that. And it's not a linear process. You can do it through planning, development, deployment, and then we typically go back to adapting it, planning it again, and so on. Now, thinking about the context for this approach, coming out of digital intervention development and human-computer interaction, there's things like usability and acceptability testing, but we want to go much further than making sure that our interventions are usable or acceptable, because if they're going to change behaviour, they need to be persuasive and engaging, not just acceptable. Now, again, human-computer interaction and those kinds of approaches do excellent user-centered design, but they usually haven't got so much of a focus on behaviour change because they don't come from behavioural science. So they're usually quite good at understanding how to make things engaging, but not necessarily how to actually change the offline behaviour, which is our target. And equally, participatory design, now that is becoming extremely popular at the moment, and rightly so, because it's very good to have users involved in the design process, and we always do. The problem with relying purely on participatory design is that the people that have the time and the capability to be co-designers are usually not typical of the whole population you're trying to reach, and particularly the harder to reach people that you really want to be able to reach. So we do extensive qualitative research with a much wider range of users than our PPI representatives. And people have started asking how our approach relates to realist methods, and the answer is completely compatible. But if you do the full-blown realist approach, you need a very sophisticated understanding of qualitative methods and social theory and a lot of time. The person-based approach is a bit simpler, and it's more focused on understanding the immediate context of individual behaviour change, because it comes out of psychology rather than sociology. So this is a lovely diagram that Leanne Morrison developed, illustrating the elements, the key elements, the planning stage that I talked about, where we formulate guiding principles, often based on literature scoping, as well as qualitative research with target users. Then we move into developing and optimizing and refining the intervention, and then finally into implementing it and using mixed methods to see how it's going in the real world. And there are complementary theory-based activities that go alongside it. So at the start, alongside our person-based approach, you would be normally doing behavioural analysis and creating your logic model, and then later refining the logic model, and at the process analysis stage, looking at theory-based questions drawn from the logic model. So what we're trying to do is complement that theory-based progression. Now, how does person-based approach complement theory and evidence-based approaches? Well, if you have tried to do a behavioural analysis and use that to inform intervention development, what you'll probably have discovered is that you can throw up loads and loads of behaviour change techniques that could be used, and it's quite difficult to decide which to use. And we find that our approach helps you decide which of all the huge range of behaviour change techniques you could use would be the most acceptable, the most relevant and meaningful for your target population. And even more importantly, it will tell you which ones are going to be disliked or are impractical, so that you can avoid them or modify them, because nothing is worse for engagement and therefore outcomes than having anything in your intervention that people don't like. So I think that's probably the most important thing that you'll get from the person-based approach. And a lot of people that I've met when I've described the approach have said to me, oh, if only we had used that approach, it wouldn't have been during the sometimes feasibility trial, but often main trial, that we discovered what it was about our intervention that meant that everybody dropped out or didn't adhere or whatever. And also, the nice thing about this approach is it tells you, gives you pointers to when you might want to develop new theory-based intervention techniques that don't yet have an evidence base to them, or sometimes they won't even have a clear theoretical rationale, but they seem to fit the context really well. So it's a nice creative approach. So now I'm just going to, in 5 minutes, quickly go through an illustration. Germ defense was a theory and evidence-based intervention that we developed. I think it was the second one we ever developed to combat infection and reduce antibiotic use, because the WHO and during the last flu pandemic, the Department of Health in the UK did advise hand washing to prevent spread of infection, but there weren't actually any interventions to support increasing hand washing. So we developed and trialled the first online intervention worldwide that did increase hand washing. And it was based on key theory and evidence-based behaviour change techniques, and then designed and optimised using in-depth iterative mixed methods research into users' views. So to give you an example, we started off wanting to do studies to select what should be the target behaviour, because there are actually several different behaviours you could use to reduce infection transmission. And one that is often used in pandemics is social distancing or quarantining. But people are very negative about that when we asked for their views in focus groups. There were some rather touching statements about, if my husband or child or boyfriend is going to have pandemic flu and be very seriously ill and maybe dying, I want to be with them, that kind of thing. So although in theory it would be a useful behaviour change technique, it's just not acceptable. Now, cough, sneeze, hygiene is actually the method that the Department of Health went for, which is catching your sneeze into a tissue and then disposing of the tissue in a bin. And everybody thought that this was a really great idea in principle, and that anything else was quite disgusting. However, most people were realistic that it's actually really difficult to have a tissue handy just at the moment you need it in order to be able to do it. So that left hand washing, which people thought was a good idea and was also seen as something that people could do. So based on this and some questionnaire work, we created some web pages to help people be motivated and put this into practice. And we did 28 Think Aloud interviews. I'm going to come back to how you do those, to find out what people thought of the website. And based on what they thought, we progressively modified it. So to start with, they told us lots of format things like, we'd like quizzes with feedback, we want the font to be larger, but we also found out really important things about the content. So we thought found out that most people before the pandemic thought that colds and flu was airborne, so they couldn't see why hand washing could help prevent infection. We found out that social influence was important to people. They didn't want to be seen as being dirty, but a practical barrier was forgetting. So based on this, these are some of the web pages we ended up with. So we started off by explaining how germs are transmitted by hand. So it is relevant to wash your hands. We harnessed key emotions. So the shame of having dirty hands and the feeling of disgust, they're very powerful emotions for doing automatic prompting of behavior. So you can see this is good theory-based stuff. And we always try to tie in our digital interventions with building offline habits, so you don't have to keep having the digital intervention prompting you what to do, so you have your natural environment prompting you. So we ask people to put in when they usually wash their hands, and so you'd find they'd put in before I ate a meal, very often, before I ate snacks. People hardly ever do. Which is strange, because with your meal you might be eating with a knife and fork and never touch it, whereas your snacks go straight from your hand into your mouth with all the germs on top. So we then got people to, based on that, to identify times that they were going to try to wash their hands a bit more and to put up reminders all around the house. And as I said, this was our second intervention. We trialled it in 20,000 adults. To my amazement, we did actually change hand washing. At the start, I'd said, I don't think a website can change a habitual behaviour like hand washing, but it did. So it got published in The Lancet. And it didn't just stop colds and flu, it stopped gastrointestinal infections, and it helped rates of infection in family members as well. And we did some analyses after to see who it worked for, and we're very happy to see that it worked just as well for example, older people, but especially people with lower education levels. I think you probably saw that we made it very accessible. And so it's now being endorsed and disseminated by NICE. So that's why I'm fairly confident to share this approach with people now, so that you can sort of do something similar with your developing your interventions and make them just as engaging. So now I'm onto the nitty-gritty of how we go about it. And I'm going to start off with how you do the intervention planning and the formulating what we call guiding principles. Now, guiding principles are kind of a summary of what your intervention users are like, what the situation is that they're in, what their attitudes are like, and therefore how that's going to influence how you design the intervention. So if I illustrate that with how we developed the guiding principles for home BP, this was an intervention to help people to self-monitor their blood pressure and then enter that into the intervention, which gave them indications of if it was above target, in which case their GP was notified and the patient was also notified that they needed an increase in medication. So we started with a feasibility study, because we actually just got a small amount of money to do a feasibility study straight away. And we did interviews with the patients and the healthcare professionals, and also focus groups with healthcare professionals. Oh, and it was also meant to have lifestyle changes, such as increasing physical activity and reducing salt and so on. Now, we always, with this kind of approach, use in-depth, what we call inductive qualitative research, which means that we use open-ended questions. We don't use theory-based questions, because if you use open-ended questions to start with, you find out what is foremost in the minds of the users. The trouble with theory-based questions is that people will politely answer all of them and will kind of make up something for every construct if they possibly can, and you won't really know at the end which were the things that were particularly important to them. Whereas if you ask open-ended questions to elicit personal stories, you can have much more confidence that what people are telling you is their genuine, what is really salient to them. So we just start with questions like, well, how do you feel about the intervention now you've had a chance to try it? We always ask about the intervention, not the website or app, because if you ask about the website or app, people will just tell you, oh, I don't really like yellow as a background colour or something like that. And everybody disagrees on that anyway. So we would say something more like, can you tell me all about the last time you tried to follow the intervention advice? And then you find out all about the feasibility barriers and so on, and the motivation barriers and the self-confidence barriers and so on, without having to prompt. So what we found out was that there was absolutely no motivation to make lifestyle changes, and people just said, the diet and the exercise and all that, I just ignored it. It's mostly platitudes that everybody knows about anyway. I didn't do it because there's no one threatening. I've had high blood pressure for many years, and I've got arthritis, so I don't do exercise. I can't do all the things they wanted me to do. And we got lots of statements like that. On the healthcare professional side, we found that actually it just wasn't working. They weren't implementing. And one healthcare professional said the communication in the team was abysmal. I got what was called an Amber Alert, which told me that, this is the patient, which told me that my blood pressure was high and I had to go and see a doctor. So I made an appointment. None of the reception staff knew what the study was about, none of the nurses. The doctor asked me what an Amber Alert was, and I had to explain to her. So I felt quite let down. So we found through our focus group with the healthcare professionals that they hadn't been checking the study emails. They couldn't remember the training they'd had, so they couldn't implement the medication changes, and they weren't really motivated to make the medication changes. So the training really hadn't persuaded them that it needed to be done. So that made us come up with some really quite important guiding principles for home BV. And we divide that normally into what we have, the intervention design objective, which was to make the implementation better by practice staff. And then the key features of the intervention that are going to achieve that. So we carefully designed automation of the interaction between the practice and the patient. So you couldn't get this situation where the patients went to the practice, nobody knew about it, because it was all automated. So we designated a practice lead for the intervention to make sure that everybody in the practice knew about it. All the training was online, and we actually automated it so that it was impossible to recruit patients until practitioners had completed it. And then the prescriber got emails directly about when they needed to do a medication change, so they didn't have to have a consultation or issue a prescription. The prescribing was pretty much automated as well, and we monitored that through the patient reports. And then we also did more motivational training for the healthcare professionals about the benefits of medication, the safety of it, how easy it would be for them to make the changes, how it wasn't going to cause any side effects, and so on. So to cut a long story short, what we found was that we've just analysed the results of the clinical trial, and lo and behold, this time it went fine in the main trial. We put those things into practice, and it did indeed reduce blood pressure, and everybody was very happy with it. So that's the sort of planning stage. Then there's the development stage, and that's when you need to make sure that the intervention that you're developing can be understood, it's acceptable and feasible, but also easy to use, motivating, enjoyable, informative, convincing, really positive, not just acceptable. And this is where the Think Aloud studies come in. Now, the Think Aloud studies, which I'm going to take you through in detail, we always do them to look at users' reactions to every element of the intervention. And I do mean every single word on every page, if we can possibly do it, if we have the time. Once we've done the Think Aloud studies, we actually then get people We do what we call a longitudinal study, where we allow users to try the intervention for a few weeks, keep diaries, and then we interview them about their experiences. That's so we get an idea what it's like using it in the real world, when we're not sitting looking over their shoulder doing think alouds. But for the think alouds, it's very simple. If you haven't come across that technique before, sometimes it's called other things like cognitive interviewing. But basically, you just ask people to use the intervention, preferably while you're sitting in the room with them. Sometimes we've done it while we're on the phone with them, and ask them to say out loud any thoughts that come to mind. And that way, you quickly find out when people click on it and go, "Oh no, I don't agree with that." And you know that you're going to have to change whatever it is you've written. You can also observe how they're using the intervention, so you can see that they have no idea where they should click to go next. So that's your sort of usability testing. And we carry on doing these think aloud studies until we're pretty sure that we can't make any more improvements to the intervention. So I'm going to give you a couple of examples of how incredibly important it can be. So to start with, there's we were doing an intervention, the diabetes literacy one, which is that one that I showed you earlier, that is in European languages and also Mandarin. And the idea was to motivate people with diabetes and low health literacy to increase their physical activity. So we developed it in English and then translated it into the other countries' languages. And then we carried out these interview studies in every country we were going to use it in, except actually Taiwan, we didn't have time to. Now, one of the key things was we were trying to create a personalised physical activity planner that would give people advice based on their current level and type of activity. And that's because we thought, you know, it's going to be much more motivating if it just gives them the next little stage of change. So, you know, it's just graded improvements in their physical activity. But we found after 35 Think Alouds interviews and modifying it all the time, only half of people could actually use it correctly and get the right feedback. And if I just show you it, this is the page we ended up with. So you'd say, how many days a week did you do this activity? And we've got all these instructions like only record activities that make you feel a bit warmer and breathe a bit harder. Walking, only count fast walking for at least 10 minutes non-stop. Heavy housework that makes your heart beat faster. We actually had to say very gentle activities such as walking slowly or washing the dishes do not count. So you can see the problems that we're having, because basically people just kept putting in the wrong amount of the wrong activities, which is why the planner kept getting it wrong and telling people, that's great, you're already doing enough activity, you don't need to do any more. Whereas we wanted them to get this feedback that says, you're not very active just now, and so you'll get lots of healthy payback, more than other people who are more active if you just do a little extra activity. So you can see that we're being very positive there. Okay, so that's how important it can be. In that intervention, if we hadn't picked up that people were completing the planner incorrectly, because from interviewing them, we knew they weren't doing very much activity, but the planner was coming out as that they were doing lots. We'd have given everybody, 95% of people would have got the feedback message, don't bother doing any more physical activity because you're already doing plenty. And since the whole intervention was to increase physical activity, that would not have been a very good thing. But one of the things that we've developed recently, because people said, well, how do you decide what changes to make, is what we've called the table of changes. So we do all these Think Aloud interviews, we transcribe them, we extract the negative and positive comments, and then we put them into the table of changes, which helps us make modifications and decide which to make. So we actually code whether it's an important change, whether it's easy and uncontroversial, whether people have asked for it repeatedly, whether it's consistent with our guiding principles and logic model, and so on. So all of these things help us decide whether to make that change. And so to give you an illustration, for example, we were trying to get the message right in a booklet, because this isn't all digital interventions. This was a booklet for underweight older people. And we were trying to advise them to have 3 big meals a day plus 3 snacks. And we found through our Think Aloud interviews, which we put into the table, people were saying things like 3 big meals and 3 snacks a day. Stone me, you've got to be joking. I've never in my life eaten that much, even during my Air Force days. So we changed it to 8 small meals or snacks throughout the day and went out and did some more Think Aloud interviews. And what we found was we were asking the same people, who goes, I certainly wouldn't find it easier to eat up to 8 small meals. 8 small meals, goodness me. So we thought, okay, let's try calling small meals and snacks smaller bites and say you could build up to it. So build up to 8 smaller bites over the day. And we gave an example of what that could be. Just a bit of toast or an egg or a drink. And finally, we got there, small bites. I should imagine that's okay. Yeah, interesting. Well, that's when I was going to be trying small bites, finger food, snacks. So we find the table of changes useful because it's systematic. You record all the comments and all the changes and why you made them. So it's very transparent, and it helps you think about why and whether a change should or shouldn't be made. And it can be very efficient for a wide research, so doing co-design with PPIs or with clinicians and other stakeholders, because you can say, well, we're only going to discuss the ones that are marked important and not the easy, uncontroversial ones. We're currently finding that completing the table with a big intervention can be too time consuming, so we're working on that and going to make it easier. Okay, and finally, how we use the person-based approach for implementation. And I'm just going to race through that because I want to have time for discussion. But it's really important to find out through either trials or real-life rollouts how people are actually using it, and then you can use that information to improve future rollouts. So for this was Power, our weight management intervention. We rolled it out in a real-life context through public health teams. And we were trying out giving 2 short phone calls at week 1 and week 4 to provide support. And we wanted to know how that was working. Now, what we found was that we did in fact get weight loss at 8 weeks, which was good, but there was no difference between people that just got the website and people that got the website and coaching. So we found out from the quantitative data that actually not that many people had even 1 phone call. So no wonder it wasn't very effective. But we also found out that when people did get it, it seemed to be useful, and it was particularly useful for people that were older, lower health literacy, higher BMI, and it led to more weight loss and more logins and so on. So then we triangulated that with some qualitative phone interviews we did, and we found that sure enough, people that did get the coaching said that it was actually helpful. It made them try harder, it helped them motivate them. But they did think that a problem was that it was when we'd said they could have them, not when they needed them. So to close the circle, we tied that back to guiding principles for future support, which we now use in our current interventions. So a key design objective is to deliver the telephone support as and when needed by the user. And the features that can achieve this is that we offer it to everybody, but we accept that many people may not take it up. We give a variety of formats, so email, phone, and face-to-face, at various time points, and with the option for the patient to initiate support. So you can see we're coming full circle back into our guiding principles for the future. So in conclusion, if you're going to put the person-based approach into practice, you may have been looking at this thinking, wow, that's awfully time-consuming. Actually, we've done it in all different ways. Sometimes we've used more stakeholder workshops and less qualitative research, all different kinds of qualitative ways of collecting qualitative data. Sometimes we've been able to skip primary data collection at the beginning and just use existing qualitative research if there was enough around. So there's lots of different ways you can put it into practice. You can use it for any kind of intervention. And although you don't have to do it in full, I always make the argument that in our studies, we very often, for example, have a programme grant where there'll be £1.5 million going into the trialling, and we will have, say, £300,000 for developing the intervention. Now, you may be gasping and thinking that's a huge amount, but it's a tiny fraction of the cost of trialling, and it's worth getting it right before you spend £1.5 million on trialling. Having said that, we have done person-based approach with just 8 or 9 months money and a very small team. So whatever you can do, it's worth trying to do. And there are more details at our website. We're continuously evolving this approach, and we're publishing papers as we go. Actually, the website itself is evolving, and you may or may not find that link works because we are trying to get it working today. So I'm going to go back, if you could, to the website link that I gave at the start of this talk. If you go into that website, which I know works, and then just click on the person-based approach tab, you can get to all our resources. Thanks very much, and look forward to speaking to you now.
Lucy, thank you very much for that. That was a very useful and interesting talk. And if there's any questions from any of our participants, they can type them into the Q&A box or into the chat box, and we can answer them. So we have a few questions already, and the first one is from James, and he asks, on the germ defense intervention, how did you make people aware or signpost people into the website? Was this also app-based or mobile friendly?
No, this was a very, very early intervention, and actually we were recruiting people from primary care because we had objective measures of consultation rates, antibiotic usage, and so on that we had to collect. So for that reason, we had to do paper-based recruitment. Obviously, now that it's just being disseminated online, it's just a question of people going onto the NICE website, which links to the intervention. So the idea was that it was designed so that if there was a pandemic, it could easily just be disseminated through the media, through a URL.
Thank you. From Dominica, she asks, for person-based approach overall, would a within-person design be helpful? For example, a number of one trial, or has it been used?
Yes, N of 1 trials we certainly have used. Leanne Morrison did a person-based approach study using mixed methods to look at the Power app we developed, because after we developed the Power website, we also developed an app to help support it, and we wanted to know how people were using the website or the app or the combination. So what we actually did was an N of 1 design where people had access to the app 1 week on, 1 week off in an ABAB or BABA design. And that's, if you want to know more, that's published in Journal of Medical Internet Research with Leanne Morrison as the lead author. But yes, we found that N of 1 was a very nice methodology to use alongside. We also did qualitative interviews with these users so that we could use the qualitative interviews to interpret the quantitative usage and outcome data that we were measuring.
That's great. From Sarah, is there a difference in the type of patients that are more likely to make change based on the intervention? For example, demographic differences, PAM levels, and are there groups that it's not appropriate for example, digital and health literacy levels?
That's a really good question, and it's quite a long and complex answer, I'm afraid.
Okay.
I think there's lots of literature showing that at the moment, uptake and usage of digital health interventions is heavily biased towards highly educated middle-class women, actually. and this is obviously really bad because it increases health inequalities. And I'm not surprised that we're seeing that, because the vast majority of digital health interventions, if you look at them, are not developed with target users in mind who have lower levels of literacy and health literacy. And this is one of the reasons why it's so important to do your person-based approach, qualitative research with a wide range of users. So we always make sure that we sample lots of people who have very low education levels, so that if there's anything that is off-putting to them, or that they can't understand or isn't engaging, we can change it. And actually what you will find is that people will want as little text as possible, very, very simple navigation, and so on. But what we've also found is that people with higher levels of education also like interventions like that. So you don't actually have to design the interventions differently for the different target groups. You just need to make sure that they're simple and engaging enough, that they're engaging for everybody. And then with our interventions, we've actually found that we've been able to engage people with very low levels of literacy and health literacy. Obviously, if people can't read or write in English, or if they don't use a computer at all, you're not going to reach them. The percentage of the population that's true of is very small, and they will need different interventions. But you should be able to reach most of the population by now. And of course, you know, there's also video formats and so on. So I would hesitate to say that you can't reach most or all of the population. But I completely agree that at the moment it's not being done well, and there needs to be a lot more done about that. And there is actually one group that actually really I do not design digital health interventions for, and that is the very oldest people with the lowest levels of income, because they're simply not online. But that group is actually aging, and you know, the people that are up to 75 now, a lot of them are online. So that group is dwindling very, very quickly.
Thank you. Claire Carroll asks, has it been used with non-digital interventions, for example, face-to-face training of healthcare professionals?
Okay, we haven't used it with face-to-face training of healthcare professionals. And obviously things like the Think Aloud interviews are designed for written materials. So we certainly have used it for written materials, and we have used it as well for developing interventions where the written material and or the online bit was only a small part of a much bigger intervention. So you certainly can go out and, for example, do focus groups or stakeholder workshops asking what people think of elements of the intervention. So I'll just give a very brief example. We were developing an intervention to change antibiotic prescribing in hospitals, and we got it funded, and in the funding we said we were going to do this, that and the other thing. So we were going to have audit and feedback, and we were going to have online training, and we were going to have opinion leaders and so on, things that the theory and literature told us we should have. And the very first sort of week, I think, I had a stakeholder workshop of all the different healthcare professionals who were involved in antibiotic prescribing. And I just presented what our ideas were about what the intervention should contain. Got lots of very constructive, critical feedback saying, we've done all that and it didn't work. And then had just a really amazing conversation about what the actual problem was in hospitals, which it turned out to be that when people are admitted, somebody prescribes antibiotics, then 24 hours later, it's a junior doctor who has to decide whether to continue with them or not. And the junior doctor doesn't know why they're prescribed in the first place and doesn't feel confident enough to change the prescription. And so they just stay on antibiotics forever because it carries on like that. So based on that, we just basically designed a classification system for the initial prescription where whoever does the prescription says it's because they think there's a probable infection or a possible infection. And then when it comes to 24 hours later, the person looking at this, the doctor, if it's just possible, feels much more confident to stop the prescription. And we have got audit and feedback, and we have got a 5-minute training app. But actually, that classification system is the key element of the intervention. It's worked brilliantly in feasibility. It's being rolled out in 36 hospitals now as a trial. And the intervention itself is not really written or digital. It's more conceptual, and it's just a way of classifying and recording decisions. So I would say that's why I say you can use it for anything, really. It's just, and you can use it in any way. It's really the principle of trying to find out what the situation is of your users, what their problem is, what the barriers are to the intervention you might be planning, and then change it so that it really works for them.
Thanks, Lucy. We still have a few questions left, so I'm not sure how much free time you have. So let me know if
I'm fine until 1.
Oh, perfect. Patrick asks that he says that the PBA sounds very effective from the examples given. What proportion of interventions developed have proven to be effective in trials?
Okay, this is going to sound really suspicious, but I'm racking my brains to think whether any of our interventions have not proven effective. And I can't think of one yet. Honestly, if you go and look at our records, our first one was an antibiotic one in primary care that was published in Lancet. Second one, germ defense, published in Lancet. Third one, Power, published in Lancet Diabetes and Endocrinology. We've got Breathe, which was in Lancet Respiratory Medicine, and so it goes on. Actually, support back fantastic feasibility trialing. This one I've just described is fantastic feasibility trialing. So, and the one, home BP, also effective, and we're just writing that up. So it really does work. And I mean, we're a brilliant team, I have to say that, in fairness to everybody else that works on the team. Having said that, some people have said, what experimental evidence do you have that the approach works? And it's very, very difficult for us to, we tried actually in a student project to get some, but it's very difficult to do, because if you know how to do this, it's difficult not to do it. You know how users think, you're going to anticipate that. And it's very difficult to justify as well, not using what you know is going to improve it. Now, it's almost the other way around. It's a little bit like, there has never been a clinical trial to find out whether it's better to have a parachute on or not when you jump out of an aeroplane when you're at 10,000 feet. And it's a little bit like that we have seen disastrous feasibility studies with our interventions, or early studies, like the examples I was giving you earlier in this session, where you can see if we'd gone straight ahead with that activity planner as it was, or with the home BP intervention as it was, those would definitely have been failed trials. But this method picked that up in time so that we were able to change it. So that's why I have a lot of confidence in the method.
Thank you, Lucy. We have a question from David, and he asks, can you tell us more about the early stages, such as the literature search and early qualitative work?
Okay, yeah, that's a very good question, because actually the kind of literature review that you need to do for the person-based approach is different from the kind you would do, for example, normal systematic reviewing just to find out whether an intervention works. Now, I know that some people do these reviews where they sort of look at behaviour, they analyse behaviour change techniques and sort of pick the ones that seem to be predicting outcome. We find that not very helpful, because whether behaviour change technique works or not depends enormously on how you implement it. As I hope that the examples that I showed you earlier show, that you can implement the same behaviour change technique well, so it works, or badly, so it doesn't. And these reviews of whether behaviour change techniques work can't take that into account. So we do a different kind of literature review a more kind of mixed methods and qualitative one. If you want to see an example, there's a paper in Psycho-Oncology, I think it was that, by Teresa Corbett, led by her recently, looking at developing our cancer intervention. Might have been in the Journal of Cancer Survivorship, but I think it was Psycho-Oncology actually. And yes, that illustrates how we do it. And it's a sort of mixed methods approach. If you know thematic synthesis, you can draw on that, where you're looking at the qualitative data about what seems to work well, what are the challenges that you need to overcome, and so on. So that's how we use systematic reviewing. And then if we just don't find enough good literature out there, especially good qualitative literature, which is what we need to understand users, then that's when we turn to doing a bit of primary qualitative research ourselves. But in some of our biggest and most important interventions, like germ defense and power, the initial qualitative work was an MSc project where we just did some focus groups. So it doesn't have to be a huge, expensive qualitative study.
Thank you, Lucy. Patrick asks again, is there a qualitative method, for example, grounded theory, thematic analysis, or IPA, that particularly informs the PBA?
You could use any of those, or whatever qualitative analysis method you feel is going to give you the best insights into users' perspectives in the context, and a lot of that is to do with the confidence you have in different methods. So any of those three would be fine, or you can use ethnography and go out and observe. That's particularly great, although we don't often have a chance to do that.
Thank you, Lucy. Jeffrey says, thanks, Lucy. Are there any areas in the PBA where quantitative methods might be preferable to qualitative? For example, in germ defense, could possible target behaviors have been ranked using online surveys from a larger and more generalizable pool of people?
Well, I promise you this wasn't like a question I planted, but actually we complemented our focus group and interviews with a online survey to find out what were the key determinants of the behaviours. We also did an online experimental study using protection motivation theory, because what we wanted to find out was it a good idea to scare people about pandemic flu? This was before the pandemic. Or should we just give them the coping information about hand washing? And what we found with an online experimental study, these are published, that particular one, Psychology, Health and Medicine, I think it is. What we found was that exactly as predicted by protection motivation theory, the combination of scaring people about the pandemic so they had higher perceived risk and giving them the coping response of how the hand washing will help led to the highest intentions to do the behaviour. So in answer, yes, absolutely complement the qualitative work with quantitative if you have the resources and time. If you had to choose between the two, I would do the qualitative work, but I would always rather do both if I could. And there's various ways that quantitative is absolutely crucial. I mean, we always have these trials. We always look at quantitative usage, we always look at quantitative outcomes. So at the end of the day, we're always quantitatively evaluating whether it really is changing, whether it's leading to engagement, usage, and whether it is really changing behavior. We always measure whether it's changing attitudes as well. So we've published quantitative process analyses of our use of germ defense, and there's a paper by Ben Ainsworth on that in Annals of Behavioural Medicine. So there's things that quantitative can tell you, the experimental method, of course, causality, and also the objective measures. Are people actually behaving in this way? Are they using it? And it's also nice if you could get psychophysiological data and so on. Often we can't get that much data, but the more you can triangulate data, the better.
Thank you, Lucy. David asks, does the approach work with parents, for example, parents of children with complex disabilities?
Yes, it absolutely does work with parents. We've used it, for example, parents of children with eczema. So we developed an intervention to help parents manage their child's eczema. That was effective, and we're now developing one for both the parents and the young people. So yes, definitely works very well with parents.
And we have a few more questions. So Alicia asks, do you have any examples of a scaled down PBA for a small team with a tight timeline?
Okay. You'd be amazed to know that actually germ defense, we did the initial development in, I think it was something like 9 months with one research associate. That was like, this is where it all comes into play, the MSc project, which was the focus group study, where everybody was saying that they wouldn't do social distancing. That helped us choose our target behaviour. Then we did a quick online survey and online experiment, just in sort of 100 people so for each, and then our quick think aloud interviews. So yes, you can. I think if you get below 6 months, you'd be really struggling to put it into useful effect. But yeah, you can do something useful in 6 months, definitely, with one person.
Thank you, Lucy. I'm conscious that it's nearly 1, so there's a lot of questions. I'm just going to ask one more and we'll have to leave it at that. So this question is from Fiona, and she says, thanks, Lucy. This session is so helpful. Do you have any advice for people looking to recruit and engage hard to reach groups for alcohol research? She's looking at a population consuming alcohol above 14 units a week, but subclinical.
I'm really sorry, but if you know the answer to that, we'd love to know as well, actually. No, I mean, hard to reach is hard to reach. I don't have any magic formula for that. It's just hard work, really, working through all the different avenues that you possibly can. I mean, we find that actually secondary care, people, when their drinking has become such a problem that end up in secondary care, at that point you can reach them. I don't know if that's helpful to you.
No, that's great. Lucy, thank you very much. This was a very interesting and useful talk. Thank you to everyone who posed the questions, and obviously a huge thank you to Lucy for your time and effort in that presentation. I personally found it very useful and informative, and I hope everyone who attended did as well. So on that note, I'd like to close the webinar, and thank you so much for your time, Lucy.
Oh, thank you very much for inviting me, and everybody for all the fantastic questions. Thanks.
Thanks
Bye.
again.